Good morning and welcome to the first session of the first day of AIOS2025. We have the Ocular Pathology, Ocular Oncology and Tumors session. I have with me our chairperson, Dr. Anju Rastogi. I am Dr. Akshay Nair and we'll be starting off. We are missing a few members on the judges and the convener panel. I think we'll start off.
Good morning. So may I request the first speaker to come forward, because I don't know in which order I should invite the presenters. Is the presenter Dr. Kritika Kanan? Is she there?
No, ma'am. I think the chief presenting author is Vishal Rawal.
Dr. Vishal Rawal. No? Okay. Dr. Manpreet Kaur, please come. So, Dr. Manpreet Kaur will be presenting correlation of impression cytology with histopathology in ocular surface squamous neoplasia.
Yeah. Please remember each free paper is for 5 minutes duration.
And since we will be marking, so please stick to the time.
Is the next speaker Dr. Ipsita Burman here? Dr. Shruti MK. Okay, so just to let you know, you're next, so you can be ready on the other side.
Good morning, everyone. The topic for today's presentation is correlation of impression cytology with histopathology in ocular surface squamous neoplasia. Introduction. So, this is not working. Introduction. The term ocular surface neoplasia was coined by Lee and Hurst. It describes a spectrum of conjunctival and corneal epithelial neoplasia manifesting as dysplasia, carcinoma in situ, and squamous cell carcinoma. Early manifestations are small masses at or around the limbus mimicking pterygium occurring in middle-aged patient. The two major risk factors are ultraviolet B light and human papillomavirus are seen to be responsible. A number of studies have been successful in detecting HPV type 16 and 18 in ocular surface squamous neoplasia. Other reported risk factors include exposure to petroleum products, heavy cigarette smoking, chemicals like trifluoridine, arsenals, beryllium, ocular surface injury, vitamin A deficiency, light pigmentation of hair and eye, and defective DNA repair in xeroderma pigmentosum. Familial origin is also seen. Infection with HIV and other immunocompromised states. OSSN is a slow-growing tumor of low-grade malignancy, which rarely metastasizes. Ocular surface squamous neoplasia can be classified as pre-invasive and invasive squamous cell carcinoma. Ocular surface squamous neoplasia can be diagnosed by certain non-invasive techniques as well as invasive histopathological examination. One of such non-invasive technique is impression cytology, which refers to the histological study of the superficial layers of the ocular surface epithelium. The aim of the study is to assess the accuracy of the impression cytology in the diagnosis of ocular surface squamous neoplasia using the cellulose acetate paper by correlating with histopathology. The study, it was prospective observation and intervention study conducted at Tertiary Care Hospital in Jammu. The study was conducted from June 2017 to December 2018. 42 eyes were included of 41 patients presenting with the conjunctival mass at the limbus at or over the conjunctiva. Hospital ethical committee approval was obtained. All inclusion criteria, it included all the patients who have the clinical suspicion of OSSN who presented to the Department of Ophthalmology during this period. Patients were explained about the impression cytology and the consent was taken. Patients with extensive involvement, patients with exclusive corneal involvement, and the patient having recurrence and the patient who refused for surgery are excluded from the study. Detailed history was taken from all the patients, best corrected visual acuity recorded, slit lamp and fundus examination was performed, intraocular pressure was measured by applanation tonometry, gonioscopy was performed, all the patients were subjected to impression cytology. In this technique, we use 4% xylocaine was instilled into the eye of the patient. After that, cellulose acetate filter paper was used and it was pressed firmly against the lesion for about 5 to 10 seconds after instilling 4% xylocaine drops. The smear was made on the glass slide using filter paper. The slide was fixed with 100% isopropyl alcohol for half an hour. After staining with H and E stain, slides were studied under light microscope. Studies were observed for the presence of dysplastic cells, inflammatory cells, hyperkeratosis, and other associated findings. Surgery. The tumor resection was performed under local peribulbar anesthesia using 1:1 mixture of 2% lignocaine and 0.75% bupivacaine. Phenylephrine 2.5% drops to include vasoconstriction. After outlining the borders of the tumor, 4 mm margin are marked with the help of calipers at the scleral edges. The conjunctiva is lifted with forceps and the first incision was made with a pair of Westcott scissors. Initial tumor dissection is localized to the marked margin. After completion of the dissection of the peripheral marked margin, the dissection was directed towards the center of the tumor. In the event of tumor adherence to the sclera, a partial thickness sclerotomy is performed with the blade or forceps. Amniotic membrane grafting was done for better healing. Once the lesion is removed, en bloc technique is used. The specimen was marked, sent to pathology in the formalin. Cytology and histopathology reports were compared. Correlation between cytology and histopathology were said to be present if the dysplastic cells were present on cytology in a patient found to have neoplasia on the histopathology. Present study results, 41 patients were included in the study. Out of 41 patients, 24 patients were males and remaining were females. 17 patients found to be above 60 years of the age as depicted in the table. Initial site of appearance was bulbar conjunctiva in 95.5% of the patients. Cytology and histopathology reports were compared. The presence of dysplastic cells in impression cytology and neoplasia in histopathology was considered as a correlation. 3 patients, 7.31% had squamous cell carcinoma. According to morphology, clinical gelatinous type constitute about 60%, leukoplakic in 13%, papilliform in 9%, and pigmentary in 16%. One patient has a bilateral presentation. Correlation between impression cytology and histopathology seen in 36 eyes. No correlation seen in 7 eyes. 85.7% patients have correlation, showing in the table. Discussion. 41 patients were included in the study. Commonest age group of presentation is 60 to 70 years with male preponderance. Most of the patients were farmers and laborers involved in the outdoor activity.
Please be brief, your time is up.
Okay,
Marks will be deducted for
the higher correlation rate in our studies is because of the presentation of the patient in the more advanced disease. In our study, we found that the impression cytology had a poor correlation in the patients having hyperkeratosis. This could be due to the scanty of the cellular yield on cytology in patients with hyperkeratosis. Conclusion of the study is impression cytology is simple, non-invasive technique with a high correlation rate in the diagnosis of the ocular surface squamous neoplasia. But the presence of hyperkeratosis on cytology has a poor correlation with histopathology. These are my references. Thank you.
Did you group your patients according to the severity of the tumor also? Did you find any difference in the correlation depending on the extent of the tumor? So in the small tumors, was the correlation as good as in the extensive tumors?
Yes, ma'am. We found a good correlation, whether it is small. We take all the patients coming in the IOPD. We take every patient who are having the growth over the limbus, at the limbus or over the limbus. Then all the patients found to be good. We found that a good correlation.
I have no questions.
Thank you.
Thank you.
I will now invite
I think the first speaker has come here.
who will be speaking on electroretinographic changes before and after IV chemo for retinoblastoma.
Okay, yeah, first of all, sorry for the delay. Good morning, one and all. Good morning to the judges. So my free paper is titled Electroretinography Changes in the Inner and Outer Retinal Layers Before and After IVC for Retinoblastoma. So just to give an overview, as we all know, retinoblastoma is the most common intraocular tumor in children less than 5 years of age, The current treatment options what we currently use is systemic intravenous chemotherapy, which is the first line of treatment in India, whereas in Western countries it is IAC and intravitreal chemotherapy as an adjunct treatment. The electroretinography changes, especially after intra-arterial and intravitreal chemotherapy, have been established, but there are reports, kind of very scarce report following systemic intravenous chemotherapy. Does the retinal toxicity is related to systemic intravenous chemotherapy? Does it have any effect on the retina, especially on the macular function test is limited. So with that understanding, we went ahead and looked at the inner as well as the outer retinal function using a full field ERG before and after intravenous chemotherapy in children with retinoblastoma. So this was a prospective observational study which was conducted at LV Prasad Eye Institute with a inclusion criteria for all the children who were diagnosed with retinoblastoma. Exclusion criteria as you can see mentioned, and the data was all the patients have undergone fundus photography using a RETCam as well as a handheld LKC pediatric ERG machine. So this is the protocol what we use in our institute. We children who have either unilateral or bilateral retinoblastoma, they are started with intravenous chemotherapy as a first line of treatment with 3 chemotherapeutic agents for every 3 to 4 weeks. 6 cycles are completed. The ERG testing was usually done in all the children under anesthesia with a RET eval system, which is a handheld LKC pediatric ERG machine, both pre and post chemotherapy, and different protocols which were ISO standards, both photopic, flicker as well as in PHNR was evaluated at each and every visit following pre and post chemotherapy. So just to give a brief understanding about what all ERG measurements, what we quantitatively measured in our study, this was related to implicit time as well as the amplitude, which was measured both at the A as well as B wave. Coming to results, in total of 6 children, 12 eyes were included in our study. 4 children had unilateral RB, 2 had bilateral RB. 1 eye was excluded, but the other eye was included because the other eye was normal, whereas the primary eye had to undergo enucleation. The mean age at presentation was 3 years, with 1 eye in group B, 3 having group C, and 4 having group D staging of retinoblastoma. 7 eyes had a macular involvement of a tumor. I think that is very important because we understand these patients might have a poor visual acuity both pre and post chemotherapy. In terms of ERG findings, or you can say the tumor regression was observed in all the 7 eyes. That was 100% response following 6 cycles of chemotherapy. In terms of ERG changes, both light adapted single flash ERG, you can see it was shortened in 4 eyes but was delayed in 2 eyes, whereas B wave again it was delayed in 5 eyes, which is close to around 2/3 of eyes. In terms of amplitude, both A and B wave were decreased in 5 and 6 eyes respectively. PHNR, this is a very important finding what we could see. This is a specific macular function test which is usually seen in this handheld ERG machines, and this was decreased in 6 eyes close to around kind of 86 to 90% of patients. So this is a representative image where you could see in one of the patient a pre-chemotherapy, you could see the ERG is showing totally flat. This is the no response in both the A as well as B wave, whereas post 6 cycles of chemotherapy, you could see there was a tumor regression that was type 3, and on the ERG also you can see both the improvement in the A as well as B wave as well as your PHNR. So this suggests that despite the chemotherapy, there was not a major influence on the retinal toxicity. However, in the other patient, you could see the pre-ERG findings, you could see there was a shortened A as well as B wave, whereas post say 6 cycles of chemotherapy, despite the tumor showed regress, but the location of the tumor in the macular location, you could see there was a reduction in both the A wave amplitude as well as the B wave amplitude in both the pre and post chemotherapies. So to key findings, what we could understand from our study, the ERG in the normal contralateral eyes remain normal, so that kind of gives a clue that the systemic chemotherapy doesn't affect the normal other eye of a retinoblastoma child. There was no statistical difference between study and normal eyes in the ERG measures at follow-up. Visual acuity, I think this is very important because these are all pre-verbal children. We could measure the visual acuity. So ERG can be a surrogate marker to measure the visual acuity in these children. And despite the macular location, I think one child only had a central fixation, whereas 2 children had a very poor fixation. And the contralateral normal eyes, visual acuity remained normal in 20 to 30 in that age group. Coming to discussion, more than 50% of eyes showed delayed photopic flash and flicker response after chemotherapy despite tumor regression. There was improvement in only in one eye, indicating poor recovery of retinal ganglion cells and amacrine cells, which is determined by the PHNR function. And IVC chemotherapy has no detrimental effect on the normal contralateral eyes. To conclude, I would say intravenous chemotherapy effects on retinal function are complex and influenced by the tumor location and associated findings retinal attachment. And the future research, what we recommend is to have longitudinal studies to comprehensively not only measure the retinal function at the macula, but also the peripheral retinal function, because as we all know, chemotherapy affects the overall retinal function. Thank you for your patience.
Thank you, Dr. Vishal. Do you think this is a replacement for examination under anesthesia for the follow-up? This examination?
No, so again, all this ERG is what we have to. So because this was a prospective study, we wanted to just look at the retinal function, how the chemotherapy, what we are giving systemically, does it affects the overall retinal function. And overall retinal function, yes, we can understand, but I think the location of the tumor, I think that was one of the confounding factor, because if it is in macular location, we understand it is going to show the reduced response as compared to your pre-chemotherapy. But again, the contralateral eye didn't show any kind of abnormality in the ERG response. I think that kind of give a clue that the systemic chemotoxicity may have a side effect in the body, but in the eye or the normal contralateral eye doesn't show any kind of abnormal retinal function test.
Yeah.
Thank you very much.
I think long-term follow-up ERG can also tell you about the duration that it takes for the retinal function to recover post-chemotherapy or post-regression of the tumor. I think that can be an important thing.
Ideally, we would want to look at every 3 weeks and look at how it is affecting the overall retinal function, might be at 1 month or 3 months, 6 months down the line. And that's where you assess the visual acuity also improvement in these children. So I think we have to have a kind of comparison between ERG findings as well as your visual acuity, how the child is improving.
But it's a good pilot study.
Yeah, thank you.
Our next speaker, presenter is Dr. Ipsita Burman. If she's not here, the next is Dr. Shruti MK. The next speaker, Dr. Manisha Supriya, is here. Okay. Mr. Nikhil Kumar. Okay, Manisha is there. So you're the next speaker, so you will be here, just to let you know.
Please start.
Okay. Good morning all. So I'll be presenting our study wherein we have evaluated orbital and ocular metastasis as the initial presentation of occult primary malignancies. So as we all know, orbital and intraocular metastasis is rare, and they present with a varied symptoms ranging from diplopia to proptosis to diminished vision. In a large case series by Shields et al., she has seen that 19% of cases there is no history of underlying carcinoma. So that was a research question. We have, in our study, outlined the spectrum of pathological changes and the clinical manifestations, imaging, and management outcomes. So this was carried out in a tertiary eye hospital with a dedicated ocular oncology service with an availability of ophthalmic pathologists, and we have 7 cases to show you. So all the samples were analyzed by a trained ophthalmic pathologist, HPV was done, customized IHC panel was done, and a recent AGCC guidelines was used for the tumor staging, and follow-up has been highlighted. So the first case was a 55-year-old lady. She came with for the management of corneal melt. A working diagnosis was idiopathic orbital inflammatory disease with exposure keratitis. And on histopathology, what we saw was large atypical cells, plasmacytoid appearance, signet cells, and most importantly, Indian file pattern. This hinted towards a metastatic disease. So we called her back, took a detailed history. We saw that she had a lump in the breast with classical malignant changes. She admitted to having noticed it a year back, but had not got it tested because of social stigma. So we went back, did the breast markers on the orbital biopsy block, confirmed it to be a mets from the breast, and referred her to the oncology center. The breast FNAC and biopsy confirmed lobular carcinoma. PET scan was done, which showed, and unfortunately, a stage 4 disease, and this patient succumbed within 3 months of diagnosis. Other case was a healthy male, 31-year-old male with protrusion of right eye, no other complaints. A working diagnosis was right lacrimal gland tumor. And then on biopsy, we found this atypical adenomatoid pattern of cells with RBC. So whenever tumor cells comes with a lot of RBCs, could be hepatogenous metastasis. So we ran a customized panel, and we saw that this was a case of lung carcinoma. So the PET again confirmed the same, and he is on targeted therapy with EGFR inhibitors. This is another case who was referred to us with choroidal melanoma, but her optos and B-scan features were more in favor of choroidal mets over choroidal melanoma in even the A-scan. That was confirmed by our retina folks, and we did a PET scan, and we saw a 2-centimeter nodule in the lung. It was a non-small cell carcinoma of the lung. This is a 3-year-old small child, came with left eye proptosis and swelling. Histopathology showed small blue round cell tumor. But then when we ran the IHC panel, it pointed towards a neuroendocrine tumor. We did the PET, and this turned out to be a metastatic neuroblastoma of the adrenal gland. Now, the following next 3 cases are hematological malignancies. So in all these cases, which presented with ocular manifestation, and in all these cases, apart from biopsy, a simple peripheral smear helped us to clinch the diagnosis. So this is a case of a 4-year-old male with upper lid fullness and hypoglobus. Peripheral smear revealed the diagnosis of acute leukemia, and cytogenetics confirmed it. This person came with a periorbital swelling, FNAC of the same end, peripheral smear showed a lot of plasma cells, and the workup was positive for multiple myeloma. This case was interesting again. She was a 14-year-old female, presented with us like an acute dacrocystitis kind of a picture. She was a known case of aplastic anemia. When we did a peripheral smear, it had transformed to acute leukemia. So this was chloroma, which was presenting in the lacrimal gland, sac, sorry. So what a study adds is orbital metastasis in an unknown solid organ malignancy occurs at later stage, but also can occur at an early stage. Surgical debulking is effective in decreasing the mass effect. Orbital radiotherapy and targeted therapy offers promising results. So as we all know, eyes are windows to your health, not just systemic disease, but even cancers from other organ system can present with orbital manifestation as the first presenting system. A keen history, a good pathology workup, and a multidisciplinary approach is the mainstay of treatment. And a timely biopsy with IHC panel, a customized IHC panel, systemic workup, a peripheral smear, and PET is mandatory in all these suspected cases. Thank you.
Thank you, Dr. Shruti. This is very interesting. And one other diagnosis which I have come across apart from some of the, the hematological malignancies and multiple myeloma is lymphoma. So did you come across any case of lymphoma which presented as proptosis?
So, ma'am, a lot of primary orbital ocular lymphomas do present with proptosis mainly, but systemic lymphomas initially presenting only when they're in a very advanced stage. So they do present with.
Yeah, sometimes they can be in the liver and present with a.
Right.
So I think in terms of ease of classification, clumping hematological malignancies along with solid organ primaries with orbital or ocular mets may not be apples and apples because hematological malignancies, once they start in the marrow and in the bloodstream, they are free to disseminate anywhere. And the presence of an extramedullary site really doesn't change the prognosis as compared to that of a solid organ like a lung or a liver or a breast, where the presence of a metastasis automatically takes you to the M0 in the AJCC. So maybe better to keep the leukemias, myelomas out of orbital mets lesions.
Totally agreed, sir. So our studies just to show that orbital mets do present as a primary in the eye, even when there is a hidden malignancy inside, undiagnosed cases.
Thank you.
Thank you so much.
So I now invite Dr. Manisha. Is she there?
Good morning, everyone. My name is Manisha. Today I am going to present a part of my thesis work entitled Exploring the Role of HIF1 Alpha and PhD1 as Prognostic Indicators in Retinoblastoma. Retinoblastoma is the most common intraocular malignancy in children, which originates from the neural crest cells of retina with incidence rate of 15 to 18,000 live births. This picture shows the most common symptoms of retinoblastoma, that is leukocoria. The most common symptoms of retinoblastoma is leukocoria, which accounts 56% of total RB cases, followed by strabismus, red painful eye, etc. The clinical management of RB patients includes patient enrollment for demographic details, direct or indirect ophthalmoscopy for examination under anesthesia, ultrasound for calcification evaluation, examination under anesthesia for staging, MRI examination for intraocular or extraocular extension, followed by treatment. Includes brachytherapy, radiotherapy, chemotherapy, or enucleation. Next, coming to the pathology of retinoblastoma, this picture shows the gross sections of retinoblastoma enucleated eye, in which tumor has brain-like appearance with chalky areas of calcification and yellow necrotic areas. On microscopic examination, retinoblastoma reveals a tumor composed of small hyperchromatic cells with high nuclear to cytoplasmic. These are the histopathological high-risk factors of retinoblastoma, which includes optic nerve cut-end invasion, optic nerve retrolaminar invasion, massive choroidal invasion, scleral invasion. This picture shows the calcification, and this is necrosis. PhD1 gene is an oxygen sensor that regulates cell metabolism, and it is a important regulator for oxygen sensing pathway in cancer. And HIF1 alpha regulates hypoxia-mediated cell apoptosis, proliferation, and tumor angiogenesis. Next, coming to the aim of this study. So the aim of this study was to explore the significance of hypoxia in regulation of oxygen sensing enzyme, that is PhD1, in RB patients, and to correlate the expression with clinicopathological parameters. This is the flow chart for this work, which includes 30 RB cases, in which 22 are primary, goes with primary enucleation, and 8 are chemo-reduced cases. mRNA expression level of HIF1 alpha and PhD1 was investigated using quantitative real-time PCR, and statistical analysis was performed to correlate the expression with clinicopathological parameters. Next, coming to the result. These are the demographic details of primary and chemo-reduced cases, in which both cases have male preponderance in this, and 27% of cases in primary have high pathological staging, and 50% of cases have high pathological staging in chemo-reduced cases. This is the flow chart for quantitative real-time PCR, and this is the reaction condition of the PCR, in which more than one fold change is taken as upregulation, and less than one is taken as downregulation. Next, coming to the mRNA expression level of HIF1 alpha in primary cases, 59% of cases shows the upregulation, and this graph shows the relative fold change expression between normal retina and RB cases. This slide represents the correlation of HIF1 alpha mRNA expression of primary RB in clinico-pathological parameters. In these clinico-pathological parameters, choroidal invasion is strongly statistically significant with mRNA expression level of HIF and alpha. This slide shows the mRNA expression level of HIF and alpha. 37% of cases have upregulation. And then the mRNA expression level are correlated with these clinico-pathological parameters, and we found the statistically significant results. This slide shows the mRNA expression level of PhD1, in which 77% of cases have downregulated.
Please conclude.
Yes. So, on conclusion and clinical relevance, this study provides evidence of oxygen sensing pathway dysregulation in retinoblastoma, and these findings suggested that the hypoxic microenvironment plays a crucial role in retinoblastoma pathogenesis by promoting angiogenesis, tumor invasion, and metastatic potential. So, therefore, HIF1 alpha and PhD1 may serve as potential prognostic biomarkers in retinoblastoma. Thank you.
Thank you. Is Dr. Nikhil Kumar here?
After Dr. Nikhil is Dr. Abhishek Das. Is Dr. Abhishek here? So you can stay in the front while he concludes, you can be ready.
Good morning, everyone. Today I'm presenting part of my PhD thesis work, which entitled Exploring Hippopathway Kinases and Cell Cycle Regulators in Uveal Melanoma. So I have no commercial interest. So uveal melanoma, as we know, that it is the most common intraocular tumor in adults with a median age of 55 to 60 years, and tumor arises from the atypical proliferating melanocytes from the uvea layer, majorly from choroid, followed by ciliary body and iris. And treatment includes brachytherapy, radiotherapy, photocoagulation, etc., and enucleation for large size tumors. So this is the clinical fundus imaging, shows the intraocular choroidal melanoma, and this is the gross eyeball of choroidal melanoma. So incidence rate, as we all know, that it is higher in white population than the Asian population, and the mean age of presentation in Asian population is 40 to 55, which is younger as compared to the white population. It metastasizes primarily to the liver, followed by lungs, bone, and skin, with a median survival of 4 to 5 months. And once metastasized, it responds very poorly to the currently available therapeutic options and leads to metastatic death in up to half of patients. So genetics of uveal melanoma is different for both, like it is different in cutaneous melanoma, which involve mutations in BRAF, NRAS, and KIT mutations, whereas uveal melanoma, the mutations arise from the GNA11 and GNAQ. So molecularly also it is classified as class 1 and class 2 based on 15 gene expression profiling. Class 1B and class 2 have high metastatic risk as compared to class 1A. So these are the clinical and histopathological high-risk factors. So histopath high-risk factors include ciliary body invasion, extraocular invasion, and high pigmentation. So these are the images of high-risk factors, which is scleral invasion, extrascleral deposits, it's there, ciliary body invasion, tumor infiltrating lymphocyte, which is having bad prognosis in uveal melanoma as compared to other tumors. So hippopathway, basically more than 90% of uveal melanoma patients harbor mutations in GNAQ or 11, which may lead to signal the several oncogenic pathways such as MAP kinase and hippopathway. Hippopathway is a key tumor suppressor pathway which regulates cell cycle and cell proliferation, and dysregulated signaling has been observed in many cancers such as breast, liver, and lung. So in the hippopathway, we have on and off states. In on state, the YAP-TAZ, which is the central mediator of this pathway, sequestered in the cytoplasm on binding with 14-3 protein, and there is no transcription of genes. Whereas when hippopathway is off, when there is a dysregulation of hippopathway due to GNAQ and GNA11 mutations, this YAP-TAZ goes into the nucleus and causes aberrant cell growth. So therefore, we aim to evaluate the expression of core hippopathway components and cell cycle kinases and to correlate with patient outcome. So this is the prospective study including 56 uveal melanoma patient samples. Sequencing is done to evaluate the mutational status of GNAQ11 and BAF1. Quantitative real-time PCR is done to perform the mRNA expression level, Western blot on representative cases, and stats. So this is the demographic details of 56 patients, in which we can say that 54% of patients have advanced tumor staging, with 27% of cases show distant metastasis, and 7 patients died out of the 56 cases. So this is the workflow for DNA exome sequencing data analysis. So this is the result for DNA exome sequencing, in which, as we can see in first case, there is variation in BAF1, frame shift variation in BAF1, and also in GNA11. Like in second case also, there is variation in BAF1 and GNA11, likewise in other cases. So to conclude, to conclude the results of whole exome sequencing, the GNA11 and Q mutations are found in almost more than 95% of cases, so which may result into the hippo pathway dysregulation. So LATS1 and LATS2, the quantitative real-time PCR results showed there is downregulation of these two genes. Also YAP and TAS were also downregulated. CDK4 is upregulated, whereas CDK6 is downregulated in these cases. So quantitative real-time PCR showed more than 70% of cases showed YAP downregulation and CDK6 downregulation. So relative phone change expression showed that LATS1 is downregulated, which is statistically significant. Also, CDK4 is upregulated, which is also statistically significant. So on Western blot analysis, the protein level also confirmed that CDK4 is highly expressed at mRNA and protein level both. So on correlation with clinical path parameters, we found LATS2 is significantly associated with advanced tumor staging, high pigmentation. YAP is significant with epithelioid cell type and distant metastasis. CDK6 is statistically significant with the epithelioid cell type, which is a poor prognostic marker, and scleral invasion. And on Kaplan-Meier survival analysis, reduced MFS was observed on upregulation of YAP and CDK4. So to conclude, basically, LATS1 and 2 kinases and YAP-TAS were downregulated in more than 75% of cases. So our finding highlights the substantial dysregulation of hippo pathway along with dysregulated cell cycle kinases. Targeting this pathway could offer promising therapeutic strategies for management of uveal melanoma. So basically, there is a drug called verteporfin which disturbs the complex of YAP-TAS. So therefore, there is it may induce apoptosis. So this is I would like to acknowledge all these my co-authors. Thank you.
Thank you. Thank you. Thank you for sticking to the time. So is Dr. Ipsita here now?
Okay, she's.
Good morning, everyone. Myself, Dr. Ipshita Burman, is here to present on the topic Indocyanine Green Enhanced Transpipilate Thermotherapy versus Transpipilate Thermotherapy for treatment of thicker tumors of retinoblastoma, a randomized controlled trial. So to start, retinoblastoma is the most common primary intraocular malignancy of childhood. The focal treatment includes laser photocoagulation, transpipilate thermotherapy, cryo, and brachytherapy. TTT is a sub-photocoagulation heat treatment using the infrared radiation of a diode laser directed at each tumor. So ICG is a green dye that binds tightly to the plasma proteins and hence remains confined to the vascular system. It also works at the peak absorption spectrum of 800 nanometer. It has been seen it is non-toxic and safe in children. So retinoblastoma most commonly present with leukocoria, strabismus being the second most common clinical feature. It can also present with red, painful eye and also diminution of vision, and atypical presentations include orbital cellulitis, hyphema, and thysis bulbi. So lacking in knowledge in our study is that very few studies are there in this treatment modality. Most of the studies done are retrospective in nature, no comparative study between TTT and ICG enhanced TTT, and no study has reported the usage of ICG as the primary or upfront treatment modality for the treatment of tumors. So rationale behind this study is that retinoblastoma is a non-pigmented tumor, while absorption of TTT is better with the pigmented lesions. ICG is a chromophore which works at the similar light absorption spectrum as the wavelength of the infrared diode laser used for TTT, and hence must augment the effect of TTT. So ICG-enhanced TTT may reduce the number of focal treatments required for thicker tumors as compared to TTT alone and achieve a greater tumor height reduction. So the primary objective of the study is to evaluate if ICG-enhanced TTT achieves a greater tumor reduction as compared to TTT, and secondary objective is to compare the complications rate between the two groups. So we included the tumor which height includes more than 2 mm, largest basal diameter less than equals to 10 mm, tumor not involving the fovea and with clear media. We excluded those tumors involving the fovea, any media haze, calcified tumors. So it is a randomized control trial for a period of 1.5 years done in RP Center for Ophthalmic Sciences, AIMS, New Delhi. So the basic methodology includes the clinical workup and examination under anesthesia to note the largest basal diameter and the height of the tumor. So all intraocular RBIs which require the chemoreduction prospectively evaluated in the inclusion in the study after 2 cycles of chemotherapy. Individual retinal tumors which fit the inclusion criteria were divided into 2 groups based on the simple randomization table. And focal treatment was continued next 4 consecutive EUAs or till the tumor height achieved a less than 2 mm. These are some clinical pictures. So the procedure includes a 3 mm spot diode laser of 810 nanometer infrared laser using 20D lens has been projected into the tumor, which heats up the tumor by 60 to 65 degree Fahrenheit, and then the energy and the duration of the TTT is increased till mild graying of the color noted. And in ICG-enhanced TTT, the dye is delivered intravenously 30 seconds before the laser treatment. So the specific tests were applied using the data analysis. The baseline characteristics of each group were comparable. The results. Coming to the results, the change in the tumor height as well as the percentage change in tumor height, it showed a significant difference between the 2 groups with greater reduction in ICG-enhanced TTT as compared to TTT group. So these are some clinical pictures. As we can see, in the 4th examination under anesthesia, there is a complete scarring with ICG-enhanced TTT and fish flash regression in TTT group. So comparing the side effects in between the 2 groups, there was no statistical difference. So to summarize, the primary outcome said, the combined use of ICG-enhanced TTT in thicker retinoblastoma has shown significant tumor height reduction. There was no significant difference between the 2 groups in side effects. So to conclude, the combination of ICG-enhanced TTT is a potentially better treatment modality in terms of treating the thicker tumors in retinoblastoma as compared to TTT alone. Limitations of the study is that it is a small sample size, also small duration of follow-up. So we recommend the combination of ICG with transpapillary thermotherapy that appears to be relatively better treatment modality as compared to conventional TTT and needs to be explored further in thicker intraocular retinoblastoma. Thank you for your patience hearing.
Thank you.
Thank you. Thank you.
I think your outcome points were very, you could have had a wider outcome measure in terms of recurrence rates, number of sites treated, number of sessions treated, the total duration. I think you were just looking at regression and side effects.
Definitely, sir. I'll take your advice. I'll do it, sir. Thank you, sir. Thank you, ma'am.
I'll now invite the next speaker, Dr. Abhishek Das. We started late, so please stick to the time.
Good morning, everyone. So today I'll be presenting on outcomes and adverse events following intraarterial chemotherapy for retinoblastoma. It's a single center study. So in the context, IAC is now a first line as well as a rescue treatment for retinoblastoma, and it is a very effective in unilateral group B, C, D, and E. And also bilateral sequential IAC is also reported. Commonly used drugs are melphalan, topotecan, and carboplatin, we all know, but very few reports on IAC and its side effects from developing country like India is reported. So it was a retrospective study. We included 17 eyes of 17 patients. Comprehensive data was collected. All the patients underwent examination under anesthesia. Imaging was done with RETCam and MRI brain with orbit. Intraarterial drugs, we used melphalan, topotecan, and carboplatin according to the body weight. So if you see the results, most of our patients were very far off distance. That means these patients came with a very advanced stage of retinoblastoma. Then we had more of unilateral. We had 11 cases with the unilateral retinoblastoma, then bilateral, and we divided into primary and secondary. So primary IAC only had primary drugs without any systemic chemo or intravitreal chemo, and secondaries were intraarterial along with intravenous or intravitreal. So if you see, most of the patients, 53% came with leukocoria followed by red eye or strabismus or only strabismus. And from the results, most of the patients were group E. So that means that most of the patients came with the advanced stage and they are very far off distance. They can't come in the tertiary center. So if you see, comparing primary IC, which had 9 eyes, and secondary IC, 8 eyes, so almost median number of cycles were 1 and 2, and we used melphalan only drugs in 2 eyes, but we usually now use melphalan with topotecan in both the groups, so 6 and 6. And in one patient, we used triple drug therapy with carboplatin, was a very advanced stage. Coming to the adverse effects, so no intervention is without risk and complications. So we found vitreous hemorrhage in 3 patients, regminogenesis detachment, choroidal ischemia, extensive RP degeneration, of course because of the melphalan, subretinal blood, forehead pigmentation, third nerve palsy with ptosis, and exotropia. So if you see the images, yes, the first image shows the third nerve palsy with complete ptosis, the B shows exotropia, third shows forehead pigmentation, which resolved over a period of time, and the D shows extensive RP degeneration followed 2 cycles of intraarterial chemotherapy. So this was one of our patients with extensive group D retinoblastoma followed by 1 IAC, everything resolved, and we did not do any further treatment for this patient. And also Kaplan-Meier curve shows, IAC shows this globe salvage rate is 93% till 5 years of age. So results, primary IAC 9 versus IAC with systemic chemo where in 8 eyes, mean age at presentation was 21 months. And mean interval between first symptom and presentation was 6.5 months, and each eye received 1.5 IC sessions. 6 patients had familial retinoblastoma, 11 had sporadic, and globe salvage was achieved in 88%. And mean follow-up of these patients were about 28.6 months. So coming to discussion, it's a small cohort study, but IAC is very effective in unilateral RB without the need of any adjuvant therapy such as in primary. If you see the cost, that is a big problem. So in IAC, one cycle approximately cost around 500 to 1,300 US dollars, whereas intravenous it all is hardly 180 US dollars. But with efforts, we tried the government to come into the limelight, and now we have IAC covered under certain schemes. And we found no statistical difference between treatment modality between primary versus secondary IAC. Private insurance, we have no coverage, that is another problem, but yes, state governments are covering systemic as well as IAC recently. So Indian context, most of the unilateral group E undergo enucleation, but we salvaged all our group E retinoblastomas and they are doing very well. We have encountered various adverse effects related to IAC and we have overcome it. But the important thing is case selection is very important. Too much over treating these patients can lead to more adverse effects. So of course, intravenous also plays an important role with active vitreous seeds along with the tumor. And more studies are anticipated, especially from developing nations like India, on the outcomes and overcoming the challenges. These are my references. Thank you.
Thank you very much. It seems the incidence is very high in the place where you're working.
Yes, because the radiologists also, they are very new to this and they don't use intraarterial in any other diseases. So, yeah.
So, just a quick question. What was the follow-up of only the group E eyes? Would you be able to?
We are now having group E more than 3 years.
Okay, because the only issue I have with IAC in group E is it does not address the potential for systemic metastasis, because a third of the group E eyes which were enucleated would have histopathological risk factors which are an indicator for systemic mets if they don't get adjuvant chemotherapy. So, but those risk factors may be mitigated if they've received primary chemo and then come for secondary IAC. Yes. So then the comparison and calling secondary IAC as the hero alone, in that case, may not be right.
Yeah, we are also doing serial MRI scans also to look for this. All right, thanks.
Dr. Bilal Ahmed.
Hello. Good morning, everyone. First, I would like to thank APO and AIOS Organizing Committee for giving me the opportunity to present my research work. That is, does mitochondria-mediated ferroptosis have a role in primary and chemo-reduced retinoblastoma? As we have already know that retinoblastoma is the most common occurring intraocular tumor of childhood and infancy. Tumor originogenesis is initiated by mutation in RB1 gene that is present in 13q chromosome. RB incident rate is more in the underdeveloped parts of the world like Africa and India with poor prognosis. Systematic chemotherapy and IAC are usually given to the treatment of RB patients. Histopathological factors that are associated with the retinoblastoma. In primary retinoblastoma, as you can see, the PDRB, massive choroidal infiltration, iris and CB infiltration, and Polony was there. And in chemo-reduced retinoblastoma, along these features, foamy macrophages, retinal gliosis, fibrosis, and cholesterol clefts are present. So there are different pathways of cell death, as we all know, but my focus on ferroptosis pathway, where the iron accumulation, lipid peroxidation, and membrane disruption takes place. And this diagram shows the different pathways that are associated with the ferroptotic pathway. So ferroptosis is a novel type of cell death mechanism where iron accumulation, lipid peroxidation leads to the disruption of mitochondrial membrane. Expression of mitochondrial genes such as mitoferrin 1, 2, BAX, CSD1, LONP1, ACSF2, and SOT2 might be involved in the induction or suppression of ferroptosis as reported in some studies. And glutathione peroxidase are a group of enzymes that are responsible for detoxifying reactive oxygen species in cell, whereas GPX4 acts exclusively in detoxifying the lipid peroxide and stabilizing the cell, thus it inhibits the ferroptosis pathway. Preliminary study shows that morphologically ferroptosis is associated with the mitochondrial disruption. In our previous study, we have seen during the TEM analysis of retinoblastoma tissues that the mitochondrial structure is disrupted, like degenerated cristae, unswollen mitochondria was observed. So this indicates that ferroptosis might play an important role in the tumor originogenesis of RB. So rationale of the study is that GPX4 acts as a central mediator of ferroptosis and it negatively correlates with the prognosis in several tumor types. Alteration of GPX4 will result in the ROS increase in the cell that will lead to the ferroptosis, as it was seen in renal cell carcinoma. An expression of mitochondrial gene, as I have already discussed, might be involved in the either inducing or suppressing the ferroptotic pathway as according to the other studies. Till date, there are no studies in literature on the mechanism of ferroptosis and mitochondrial mediated pathway in retinoblastoma tumor. This provides us the opportunity to develop prognostic biomarkers and targeted therapy with the use of ferroptotic inducers and chemotherapeutic agents in the survival of retinoblastoma patients. So these are the studies that are done on the mitochondria and apoptosis in RB, and these are the literature that are available on GPX4 role in ferroptosis. The aim of this study was to investigate the gene expression pattern of mitochondrial and antiferroptotic gene GPX4 in primary and chemo-reduced RB tissue samples. So our methodology includes we have included 71 tumor samples where 51 belong to primary RB group and chemo-reduced belong to 21 cases. We isolated the RNA, then cDNA, and we done the qRT-PCR on those genes. These are the clinical pathological details of primary and chemo-reduced RB. As you can see, the male preponderance was present in both the groups. And these are the reaction conditions for qRT-PCR, where the fold change value is calculated by 2 minus delta CT method, and 1.5 above fold change is taken as upregulation. These are the expression levels of mitochondrial genes. And this slide shows the expression level of GPX4 in both primary and chemo-reduced group. In GPX4 expression was higher in the primary group by 52%, and chemo-reduced it was down-regulated by 71%. These are the graphs with respect to normal retina. So to conclude in our study, mRNA expression reveals that LONP1 and BAX was subregulated in primary RB cases like 78% and 86% respectively. In chemo-reduced RB cases, similar pattern of mRNA expression of mitochondrial gene was observed, except ACSF2 that was increased in 53% of cases. Antiferroptotic genes GPX4 was upregulated in primary cases, whereas downregulated in 78% of the chemo-reduced RB group. This result indicates that GPX4 expression in RB sample might play a crucial role in suppressing cell death mediated by ferroptosis affecting the tumor originogenesis in RB. Further studies might give better insight into understanding the contribution of GPX4 as potential biomarker in prognosis of retinoblastoma. take away home messages. GPX4 is a central mediator of the ferroptotic pathway. I would like to acknowledge my co-authors, and I would also like to thank ICMR for providing the funding and all the patient and their parents. Thank you.
Thank you. Dr. Rolika Bansal.
May I begin?
Yes.
Okay. So I'll be talking today on triple drug super-selective ophthalmic artery intraarterial chemotherapy for retinoblastoma in Asian Indian population. And I thank APO, AIOS, and my mentor for the opportunity. So over the time, we have seen that the mortality rate in the last 1 century has gone from 85 to 90% all the way, and has switched to a high survival rate of more than 90%, which has been proven recently even in the ICMR consensus guidelines. And this has been due to the recent advances in retinoblastoma, including the intra-arterial chemotherapy, which is basically introduction of the chemotherapeutic agents all the way directly into the ophthalmic artery by hooking the catheter to the ostium, and that's what it is called super-selective approach. A number of studies have been done in the past, and over the past we have seen agreements and disagreements, and several analyses have been carried out to make and purify the intraarterial chemotherapy to a higher level. It has been over 15 years, and multiple drug regimens have been seen. Single drug regimens, double drug, triple drug, mixed drugs. However, the astonishing part is that triple drug regimen, only one study has been done, and which is basically of 22 cases, which was a preliminary study done in 2012. So we studied the triple drug regimen to break the concept of complications that have been anticipated in the Asian Indian population. And we analyzed 163 eyes undergoing primary or secondary IAC with no baseline metastasis or loss to follow-up. We gave topotecan, carboplatin, and melphalan even in the given dose range, and we saw that IAC constituted 9.5% of all the active treatment patients, with the mean infusions of 2.5, which is a very interesting number. That means we're giving less number of infusions. We gave infusions to unilateral and bilateral RB cases as primary IAC and secondary IAC. And we saw a striking low number in 3% of primary IAC in bilateral cases. This is based on the study that has been stated earlier by Shields, and that is that we must think about IVC over IAC in bilateral cases because the priority is to save life. However, the agreements and disagreements between the pioneers of IAC, they continue even in the developed nations. And it has been shown that we must remember that the cost is definitely a major factor when it comes to developing countries. And it has been shown that, it has been proven that IVC is nearly 10 times cheaper than IAC, and that of course brings down is one of the factors over here. And intraarterial chemotherapy has shown an underplay even in the case, even in the global retinoblastoma study group where retinoblastoma in Asia was documented. In our cases, most of the cases were group D or E, that is in the advanced cases. We saw excellent outcomes with primary IAC. Here, complete regression in the lower groups. Group D saw 51% regression in group D, and group E showed 22% regression, which are good numbers. And we also saw that in cases with refractory RB, residual RB, and even the tumor recurrences, secondary IAC was given, and it showed excellent response in cases like, which is resistant to focal therapy, cases with massive recurrence, with peripheral recurrence, with vitreous seeds, recurrence overlying the calcified mound, all gone, and optic nerve head recurrence also showed an excellent response. However, we did not see enough good response in cases with vitreous hemorrhage or with anterior chamber seeds, and therefore a 54% globe salvage by secondary IAC was obtained, which is a very high number. Out of the enucleated eyes, we saw only 30% eyes which was due to chemoresistance and refractory tumor. 29% showed histopathological risk factors which were given adjuvant chemotherapy, and Kaplan-Meier survival showed that 5-year enucleation-free period was 72.6% overall. When we compared the studies, we saw that we were able to achieve a 5-year Kaplan-Meier survival, which was very high numbers, and we saw a high salvage rate in advanced cases as well. We were able to get a lower number of cycles, at least we're cutting down the cost and helping down the patients, and with excellent salvage rates, and at a good follow-up rate. So life salvage of 100%, eye salvage of 54 to 89%, and vision salvage of 16 to 25% was obtained. So to conclude, 9.5% of active patients were treated with ISC, factors dependent on laterality, affordability, and grouping. We led to reduction in the number of cases. Advanced retinoblastoma showed salvage rate of 54% with 100% life salvage, bypassing the systemic effects, and HRF must be assessed with adjuvant chemotherapy to all. So it's all about one day at a time, and I thank our patients, parents, and the team members for the positive mindset. Thank you.
Thank you for a good presentation. We will keep the questions for the end because we have a lot of speakers yet to come. Thank you. So next speaker is Dr. Elika Gupta.
She's not here.
She's not there? Okay. Dr. Vinod Kumar Singh.
Okay.
No? The next speaker, Dr. Ruju Unadkat.
Forge your weapons in the fire of need. How? Let's figure out with this presentation on dose-escalated intravitreal topotecan in retinoblastoma. Vitreous seeds have been identified as the most common cause of treatment failure post-chemotherapy. Intravitreal injection of chemotherapeutic agent solved this problem to quite an extent. It started with melphalan given in dose of 8 microgram, but high rate of recurrence was noted. So a shift to 50 microgram was done, but soon discontinued because of its propensity to cause retinal toxicity. So now new balance was found between 20 to 30 microns. Melphalan was then challenged by topotecan because of its effectivity, safety, and stability for longer duration. But refractory vitreous seeds were still a challenge, so a practice of combined topo plus melphalan was initiated. Also, effectivity of intravitreal topo at the dose of 30 microgram was emphasized. However, suggestion of high dose 90 microgram opened an entire new window of hope, specifically for its use with subretinal seeds and recurrent retinal tumors. So our study was designed with a purpose of evaluating role of dose-escalated intravitreal topotecan in terms of its efficacy, safety, complications, and outcome. It was a retrospective, consecutive, non-comparative observational case series which included 31 eyes of 31 cases over a period of 35 months. However, cases receiving any form of concurrent IVC or IAC were excluded. All the cases with focal seeds only in one quadrant were given IVT in dose of 30 microgram. Seeds in 2 quadrants received 45 microgram, seeds in 3 quadrants received 60 microgram, and highest dose of 90 micron was given to those with diffuse vitreous seeds or seeds in all 4 quadrants. For focal subretinal seeds, dose of 60 micron was given and escalation to 90 was done for diffuse subretinal seeds. Cases with less than 3 mm size small retinal tumors were given IVT in dose of 90 micron. Following are the derived results of demographic details. Majority of cases belong to baseline group D and E. Most common indication being diffuse vitreous seeds. Out of total 27 cases with vitreous seeds, primary dose escalation was done in 44% and 56% required secondary dose escalation. Interestingly, we found that with the secondary dose escalation, average number of injections required reduced to half. This case with diffuse seeds received 90 microgram IVT and laser TTT for the residual tumor and showed complete regression. This case with dense cloud of vitreous seed completely regressed and cleared after 5 injections. Case with juxtapapillary seeds regressed and became amorphous. In this very interesting case of diffuse vitreous seeds, patient initially responded well to 30 microgram, but soon became refractory, but regressed completely after dose escalation to 90. Of total 9 cases with subretinal seeds, all responded well with an average of just 1 IVT. Yes, you heard that right, with just 1 IVT. In this case, with small retinal tumor recurrence, which was refractory to TTT, regressed completely with just 1 IVT. Trial of IVT was also given to cases with endophytic budding type of recurrences, cases with multifocal recurrences, case with juxtapapillary tumor recurrence or optic nerve head tumor where TTT is unfavorable and showed satisfactory outcomes with complete regression in all. This is the regression pattern observed, and 62% regressed with a flat scar with an average of 1 injection. In a mean follow-up of 6 months, we noticed cataract in 2 cases and injection site cystoid cicatrix in 9 cases. Till the end of our study, 21 cases remained regressed, but 10 cases showed recurrence with an evidence of main tumor recurrence in 6 cases. Rate of recurrence derived for vitreous seed was hence the highest, 33%, and lowest for subretinal seeds, 0%. On reviewing the literature, there were only 2 similar published studies, but ours was the largest in terms of sample size. For retinal tumor, initial tumor control was 100% in all the series, and rate of recurrence was identical and highest for the vitreous seed. So to conclude, I would like to say, despite best of our efforts, eyes which were initially unsalvageable because of resistant or refractory seeds or recurrent tumors are now amenable to eye salvage by adopting a tailored approach, that is dose escalation between 45 to 90 micron as an effective and safe modality. And lastly, I would like to thank by saying refined arms are truly savior's art.
Thank you. So, quick question. The ones who actually recurred after systemic therapy and IVT, were they then eventually enucleated or plaque or radiation?
Out of total 10 cases, 4 required enucleation, and all 4 of them had massive vitreous seed recurrence. So that is also one factor which we derived, that for enucleation eye which could not be eventually salvaged, vitreous seed recurrence was the major factor for that.
Thanks.
Thank you. The next speaker, Dr. Aruja Gangwani.
Good morning, everyone. I'll be presenting my paper on indigenous ruthenium plaque brachytherapy for ocular tumors, experience from a tertiary care center. So plaque brachytherapy is a form of local radiation that is delivered to the eye via radioactive device, with the most commonly used ophthalmic plaques being iodine-125 and ruthenium-106. The BARC has recently introduced the indigenous plaque to make plaque brachytherapy treatment affordable and available in India. So we report our experience with the use of this indigenously developed ruthenium plaque in the management of ocular tumors. So we conducted a retrospective review of the clinical records of the ocular tumor cases treated with the plaque brachytherapy at our center. The plaque that was used was indigenously developed in collaboration with BARC Mumbai. Demographic information, clinical details, and radiation dosimetry of the cases that were treated with plaque brachytherapy were noted and analyzed. So we did a complete preoperative evaluation of the type of tumor, the size and location of the tumor by clinical examination and imaging. And we had 2 ruthenium plaques. One was a notch plaque, the other was a round plaque of varying diameters that we used for our study. We gave local and general anesthesia depending on the age of the patient. Peritomy was done, the plaque was positioned, and the radiation was delivered for the predefined period. And subsequently, the plaque was removed. So we identified a total of 47 cases that have been treated with indigenous ruthenium plaque brachytherapy between the years 21 to 23. The mean age was 27.5 years, and we treated both pediatric patients with age ranging from around 9 months to adult patients to age almost around 70 years. We treated both benign and malignant tumors. So coming to the most common indications for treatment with indigenous ruthenium plaque brachytherapy, choroidal melanoma accounted for maximum of our patients, followed by retinoblastoma. We also treated other tumors like choroidal hemangioma, OSSN, VPT. So coming to the mean apical thickness of the tumors that we treated, it ranged from around 1.45 mm in OSSN to around 5.59 mm in choroidal melanomas, with the mean duration of application ranging from around 8.2 hours to around 60 hours. The mean dose ranged from 62 grays to around 321 grays. So all the cases were effectively treated with the use of indigenous plaque, thereby showing its utility in a wide range of benign as well as malignant lesions of the eye. So the key points that I would like to highlight is that we treated both benign and malignant tumors. We treated both pediatric and adult tumors and tumors of varying thickness. So previously we have indigenously developed AIOS2025 Ocuprosta seeds which have been used for plaque brachytherapy for various intraocular tumors. And these seeds offered a viable option for the management of intraocular tumors. However, iodine is a gamma emitter while ruthenium is a beta emitter. Ruthenium is preferred because the radiation gradient surrounding the ruthenium plaque is steeper than that found with the gamma emitter. Also, ruthenium is a cost-effective alternative as it has a longer half-life, and the same plaque can be reused for a large number of patients as its shelf life is more than a year. Thus, the ruthenium plaque is actually a cost-effective alternative. I would like to conclude by saying that plaque brachytherapy can be used for many different types of ocular tumors. The indigenously developed ruthenium plaque was found to be promising in a wide variety of malignant as well as benign tumors of the eye and ocular surface in both adults and children, and it offers an effective and inexpensive alternative to the imported plaque, particularly for use in clinical settings with limited resources. Thank you.
No, I think it was well presented. Thank you.
The next speaker, Dr. Abha Gupta, are you there? Yeah. What is the rationale for giving toxic drugs in a benign tumor? Dr. Aruja, can you answer that? Has she gone? Use that. Use that.
Larger in size and had associated large exudative retinal detachment and were not amenable to TTT. So in those cases, we have used plaque brachytherapy.
Okay, thank you. Start.
Hi, good morning. I'll be presenting sequelae and management of radiation-induced complications in retinoblastoma. I have no financial disclosures. So the purpose of our study was to discuss the post-radiotherapy complications in patients of retinoblastoma. It was a retrospective analysis of treatment record of retinoblastoma eyes treated with radiotherapy from January 2004 to May 2024. Treatment record of 14 eyes of 14 patients was analyzed on following parameters: the age of presentation, the laterality, the family history, international classification of retinoblastoma, complications, and how we manage them. So coming on to the results, foremost, there were 2 patients which were unilateral retinoblastomas and rest 12 were bilateral cases of retinoblastoma. Family history was present in 4 patients of retinoblastoma and absent in 10 patients of retinoblastoma. Coming on to the classification, 6 patients belong to group B, 3 patients belong to group D, and 5 patients belong to group E. So 12 patients who received radiotherapy as a primary treatment modality, out of which 6 patients were from group B, 3 patients belonged to group D, and 3 patients belonged to group E. And 2 patients in group E received the post-enucleation due to choroidal invasion and optic nerve involvement in the enucleated sample. 9 out of the 14 patients received low dose of chemotherapy that was less than 35 centigrays, and the rest received high dose radiations. Coming on to the complications that we encountered, so the most common complication that was occurring post-radiation was the presence of post-radiation cataract. It was present in 7 of our patients, and all of these were managed with phacoaspiration, with posterior chamber IOL, with anterior vitrectomy, and primary posterior capsular excess. Radiation retinopathy involving the macula was present in 3 of our patients. All of these were managed with three doses of intravitreal anti-VEGFs, that is ranibizumab. Secondary tumor as a meningioma was present in one of the patient, which also had a family history and underwent neurosurgical intervention for the same. There was presence of contracted socket post-radiation in 2 patients, which was again managed on serial dermis fat grafts and fornix forming sutures. And a serious complication of growth retardation was documented in 4 of our patients, which was managed with hormonal therapies. So just coming on to the discussion, retinoblastoma is a highly curable neoplasm in high-income countries, but in stark contrast to lower-income countries where most patients present with disseminated metastatic disease. And the evolution in the conservative treatment has gone from local to eye-directed therapies such as EBRTs towards systemic chemotherapies combined with aggressive focal therapies. So just to conclude, the only thing that a study found was that it highlights a high globe salvage rate that was achieved with patients who received radiotherapy, but yes, it is been associated with more complications. However, we do say advanced stage retinoblastomas have higher chances of globe salvage if they were given timely radiotherapies. Thank you.
Thank you. And a quick question. You had group B, D, and E eyes in which primary radiation was given.
No, sir. Primary radiation, just a second.
Sure.
Yes, sir. We gave primary radiation in group B RBs. One eye was group B, other eye was group D.
Group A?
Group D.
D.
Yes, sir.
Why would you not think of, we've just gone through multiple talks of IAC, IVC, systemic chemo with
Yes, sir.
focal over radiation over systemic or focal or intra-arterial, given the side effect profile of systemic and intra-arterial is so much lesser compared to radiation to the whole eye.
So that was the purpose of the study. This is a retrospective analysis that was done as to what the primary surgeon was trying to do retrospectively, and then we decided to find out what exactly were the complications that happened.
All right.
Thank you. Dr. Tithi Kundu, please come.
Should I start? Good morning, one and all. I'm Dr. Tithi, and I'll be speaking on treatment outcomes in extraocular retinoblastoma and its correlation with the pattern and extent of spread. Now, in developing nations such as ours, children affected by retinoblastoma have considerably lower survival outcome compared to developed nations, largely attributed to the higher incidence of extraocular retinoblastoma in these regions. The current staging systems, that is the IRSS and TNM, are most widely adopted presently. In the International Retinoblastoma Staging System, orbital RB corresponds to stage 3, and extension beyond the orbit is a metastatic stage 4 disease. However, the extent of orbital involvement is not further subcategorized. A clinically aggressive anterior fungating mass with tumor extending transclerally up to mid-orbit is categorized in the same stage as this child who has no extraocular signs clinically, but on imaging showed optic nerve invasion till the apex, thus having a much poorer prognosis in comparison. So we have to ask ourselves if the clinical radiological findings correlate with the prognosis. A similar fallacy is found in the TNM staging system where orbital RB falls in T4A and 4B category. In clinical practice, however, advanced optic nerve involvement without anterior signs, a category 4A in TNM, shows much poorer prognosis compared to an anterior fungating mass, which is T4B. In both these staging systems, the pattern and extent of tumor spread and their correlation with survival outcome is not addressed. So through our study, we aim to address this limitation by evaluating the pattern and extent of orbital involvement on imaging and correlating the set findings with survival outcome in these patients. In this retrospective observational study, we included patients
who were diagnosed radiologically as extraocular RB, who had a good primary imaging films which were available for reevaluation, an available staging workup data, and a known follow-up status. Our expert neuroradiologist reviews the scans of the children and categorizes the tumors based on route of extraocular spread, that is whether it was scleral or optic nerve, and the anatomical extent of involvement was graded as follows. 0 depicts nil involvement via the said route. S1, 2, and 3 depicted involvement of tumor up to anterior 1/3, middle third, and near total orbital involvement. In tumors involving optic nerve invasion, N1 was intraorbital involvement, N2 depicted involvement up to intracanalicular optic nerve, and N3 was extent beyond the intracanalicular part. These are some of the scans with their respective S and N extents. The findings varied from isolated scleral breach, isolated optic nerve thickening, and various permutations of combined involvement. The demographics of the 45 children are as depicted, and these were the most common presenting signs and symptoms. While there were 8 cases each of isolated optic nerve and isolated scleral extension, most cases showed a combined spread pattern. This table depicts the distribution of 45 patients based on their S, that is scleral, and N, that is optic nerve severity from 0 to 4, along with the survival outcome. The S and N categories were grouped in increasing order of severities, and level-specific death rates were calculated for each category. It is clear that even though the existing staging systems place all these patients in a single category, there's a large variation in the level-specific death rate, ranging from 6 to 50%, based on the anatomical extent of the tumor, even within the same group of orbital RB. Thus, a one single fit is not valid for all the patients. The graphical representation of the same proves that all scleral and optic nerve are not the same, and death rate rapidly escalates with increasing scleral and optic nerve extent severity. So a novel imaging-based system subcategorizes a large pool of extraocular retinoblastoma, thus helping prognosticate better. Higher the S on N extent level, more is the mortality. This subclassification will help us break this large group of extraocular RB into smaller division, which the current systems fail to address. Incorporating this radiological extent-based system into clinical practice may aid in risk stratification of patients for future clinical guidelines and help personalize management based on tumor behavior. Further multicentric studies, of course, are needed with larger cohorts to validate the system and explore its application in diverse clinical settings. Thank you very much.
It's a very novel paper because this is something new. In literature, has there been any similar grading or subgrading of orbital spread? And if gun to your head, which is worse, a higher S or an higher N?
So we are a higher N is definitely worse. Because we have seen in anterior fungating masses, there might not be posterior extension to the apex or to the optic nerve. It's mainly a fungating in transferring to the scleral spread.
Right.
But they have a better prognosis.
So also you included only survival, or whether they were surviving or whether they were dead.
Yes.
Did metastasis, distant metastasis, have a correlation with S or N?
So in our case, in patients presenting with overt metastasis, we have excluded them because by default we have mainly included orbital RB.
Without metastasis?
Without metastasis on imaging or without overt signs of metastasis.
All right. So maybe that could be your next step, where you expand all cases of orbital RB and see which ones have more mets, whether it's S or N.
Yes.
Thanks.
Yeah, thank you. Dr. Puneet Jain.
A very good morning to everyone. So RB heavy session, I would like to conclude with a different tumor. So I'll be speaking on metastatic conjunctival melanoma. This study is supported by the Eye Cancer Foundation. So just a background, we all know that conjunctival melanoma is a very rare tumor, and there are reports which say that the incidence is on the rise. Despite the best local management as an ocular oncologist, the metastatic rates and the tumor mortality remains very high, to the tune of 40%. Of late, systemic immunotherapy has been shown to be effective in control of metastatic disease. So this is a registry-based study. The idea of the conjunctival melanoma registry came into being on the first Eye Cancer Day. This is way back in 2015, almost a decade back, when 10 ocular oncology centers collaborated, and this was an internet-based data sharing study involving 10 ocular oncology centers from 9 different countries. So we analyzed the data. The data analysis began in somewhere in 2016. The first paper came out, which was basically to validate the 8th edition of AJCC, which was which just came out at that time. The second paper spoke about the local recurrence rates. This paper focuses, we further analyzed the data, and this paper focuses only on the metastatic subset of patients. So just to give an idea of the cohort, there were 288 patients in this study, and 75% patients were T1, CT1 stage, and there were no CT4 tumors in this study. So overall, 29 patients had metastatic disease, of which 5 had at presentation and 24 developed metastasis during follow-up. The ones that had metastasis at presentation, all of them were multicentric tumors, and 4 of 5 had plical and caruncular involvement. All were staged CT3. All were thicker than 2.7 millimeter. Lung and liver were the most common site of metastasis, and tumor ulceration was present in 4 out of 5 patients. Only 1 patient survived beyond 1 year. The rest of the patients passed away within 1 year of presentation. 24 patients subsequently developed metastasis in follow-up over a median follow-up at a median follow-up of 4.2 years. Note was important that we would expect multi-organ metastasis in these patients, but in our study, liver was the most common sign of metastasis, followed by lung, and lung and liver were the most common combination. And on the contrary to what we would expect, that local recurrence might precede a systemic showing up of the tumor on annual monitoring. More than 50% of the patients develop metastasis without local recurrence in this study. The cumulative risk of systemic metastasis was less than 1% at 1 year, and it shot up to 22.3% at the 10-year follow-up. 17 patients out of 24 died in the duration of the study. Of note is that the data was collected prior to introduction of systemic immunotherapy, which has shown promising results in life salvage in such patients. Just to keep things in perspective, with every 1 stage increment in T stage, there was an 89% higher risk of systemic metastasis, and with every 1 millimeter increase in tumor thickness, there was 16% higher risk of metastasis in such patients. Another notable point was that upon spread, the distant metastasis was more common than the lymph node metastasis. Now, we usually in our clinics look at local recurrence and palpate the lymph nodes, and probably might be tempted not to get the systemic evaluation done. It just highlights this point. It's kind of a controversial point, but this is what the study, our study found out. So all the patients with metastatic at presentation had 100% mortality at 2 years, and those with follow-up, if metastasis happened, had 10% mortality at 2 years and 40% mortality at 5 years. This is a busy table showing the comparison between the two groups. Of note is that multicentric tumors, plical and caruncular involvement, tumor thickness are very important factors for patient might be having metastasis at presentation if the patient were to present to you. This is where we compared our previous study, where local recurrence was not found significantly associated with plical involvement, caruncular involvement, but metastasis was found to be associated. The weakness of the study is that it has a retrospective study with small numbers of T3 and T4 tumors, but it is a multicentric study that represents real-world outcomes. To conclude, this multicenter study was able to gather statistically significant data about rare ocular malignancies, and overall AJCC stage was higher, and survival was shorter in patients with metastatic conjunctival melanoma. These are my references. Thank you so much.
Thank you. Well presented. Before we conclude, just a reminder, to check if Dr. Elika Gupta and Dr. Vinod Kumar Singh are present. All right. I think we can close the session.
Yes, thank you very much. If there are any questions, quick questions for the speakers, we can take one or two. Otherwise, we will close the session. Thank you.